Hi there, I'm Ryan Madnick. Today's my first trial of video logging or video blogging or whatever you want to call it. So we'll see how this goes. Thanks for tuning in. It's day one of DDW. If you follow me, you know that I'm at UNC. I'm an assistant professor of medicine, and I work in the esophageal center there. I run the fellowship program, and I do a lot of teaching. And I've just started a blog, and I tweet on Twitter. Ryan Madnick, MD, and the spelling of my last name is Madanick, so in case, for what it's worth. Anyway, I want to tell you a little bit about what I saw at DDW today and some of the highlights. Let me start with the posters. Unfortunately, I didn't get to many of the posters today because I was presenting my own poster today, so I'll tell you about my own poster. I am posting a link on YouTube about that. That'll eventually come up, if not on my own new channel, then on the DDW channel. I looked at cost effectiveness of testing people with refractory GERD symptoms on therapy versus testing them off therapy. Basically what I found in a cost utility model was that over a 10-year period, it's much more cost effective to test them on therapy than it is to test them off therapy. You get better outcomes and it costs less. So that's I'd say the highlight of the poster session. I did get a poster of distinction out of it, and it was poster number 1000. I got good foot traffic through my poster today. I was literally at the very, very front of the poster hall. Everyone went right by my poster as they walked in. So got a lot of good comments, and hopefully that paper will be in review within the next couple of weeks. I went to 2 sessions today, both of them having to do with esophageal disease and PPIs. The first session was a symposium about the risks of PPIs in clinical practice. And this is a very hot topic right now. The risks of PPI use in clinical practice are getting a lot of press with Clostridium difficile, C. diff, pneumonia, Plavix or clopidogrel. Basically what it came down to was that there are a lot of data that are mainly epidemiologic in nature, and we don't really know how that translates into clinical practice. If a patient deserves a PPI use for whatever purpose, then they should be on a PPI. The dose should be minimized as much as possible, but if they have a good indication to be on a PPI, meaning they need it for gastric protection because they're on Plavix and aspirin, they have a high risk for bleeding, or they have symptomatic GERD, or they have complicated GERD, or they can't come off it for some other reason like dyspepsia where they need their medication to control their symptoms, they should be on the medication. Understanding that there's possible risks, they should stay on their medication and manage the potential for risks in other ways. And that's really the highlight of what we should be talking about. If they don't have a good indication for PPI, take them off of it. And as long as they don't have significant symptoms that return, you can stay off the medication. So that was the highlight of the symposium for risk of PPI use in clinical practice. So the next session I went to was the manifestations of extraesophageal reflux disease. And the real highlight of this came from Mike Vasey from Vanderbilt, who did a state-of-the-art talk at the end of the session. Basically what he said was that our knowledge about this problem is evolving, that it seems that most of the people who have extraesophageal manifestations of reflux disease probably also have esophageal manifestations, meaning heartburn and regurgitation, and then the patients that have purely extraesophageal manifestations, or I should say purely extraesophageal symptoms, meaning cough, sore throat, clearing of your throat, postnasal drip, etc., who have no other reflux symptoms, you should probably take a very skeptical eye about even testing them and sending them on for surgery if they're positive. I think there's a lot to be learned as we go forward with the outcomes. He stressed that we need outcomes in this, but that we should not just attribute all that's in the throat to reflux. Just because that's the only thing that we know of that could be causing it right now doesn't mean that that is the only problem. So I think we have a lot of research left to be done. Dr. Vasey's leading the way, and hopefully my group will also contribute to that in the future. So that's the end of this video blog. Hopefully tomorrow I'll be able to do it again. Take care.